Welcome, everyone. I just wanted to point out some logistics. If you don't see the closed captioning, if you could just go to the toolbar for Zoom and click on CC button and click on show subtitle. That way you are able to utilize the closed captioning for today's talk. And also, I wanted to welcome our guest speaker today, Ariane Ramirez. She will be talking to us about healthcare disparities in women with disabilities in honor of Disability Awareness Month. We have several events this month, virtual events throughout the month. So if you haven't registered already, please look out in your employee update emails and register using the link provided. And we hope to see you at the other webinars that we have for you this month. So Ariane is a clinical research coordinator with the Spinal Cord Injury Program with the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai Hospital. So we're really honored that Ariane was able to join us here today. And I'm gonna hand it over to Ariane to start her presentation. And if you at all at any point throughout the talk have a question, please put it in the Q&A and we'll get to those questions towards the end of the presentation. Thank you.
All right. Good afternoon, everyone. Thank you all for joining us. Thank you, Mary, for a wonderful presentation. So today I'll be discussing the 3 biggest healthcare disparities that affect women with physical disabilities. I'll speak a little bit about my personal experience and also highlight some of the work that my lab, the Spinal Cord Injury Program at Mount Sinai, is working on to improve some of these outcomes. If non-disabled people first thought after learning about a disabled person's story was, okay, what can I do to dismantle the ableism they face? Rather than, wow, I can't imagine living like that. There's such an inspiration. The world will be a much better and accessible place. I start with this quote to highlight the biggest obstacles that I face in my life as a woman with a disability are the barriers that society places on me. Why are disabled people's existence something to commiserate rather than put the attention on the systemic and societal issues that we face? Yes, there are difficulties with having a spinal cord injury. I had an accidental fall at the age of 18 that left me paralyzed from the waist down. But my life would be so much easier if the world was designed with disability in mind. These systemic barriers are prevalent in all aspects of society, including healthcare. Approximately 36 million women in the US have disabilities, and the number is growing. Disparities in healthcare represent a serious public health issue, given that almost 13% of working age women in the United States have a disability. So what is the problem? Women with disabilities face more difficulty than non-disabled women in accessing healthcare screenings. This includes routine physical exams, mammograms, pap smears, or other pelvic exams, sexually transmitted infection screenings, eye exams, among other numerous ones. So I look at the numbers. Nearly 1/3 of women with physical disabilities reported being denied services at a doctor's office solely because of their disability. Women who have major difficulties in walking are 40% less likely to be screened for cervical cancer compared with other women. Women who have major difficulties in walking are also 30% less likely to have mammograms for breast cancer screenings compared with other women. While women with and without disabilities are equally likely to desire pregnancy, once pregnant, women with disabilities may be less likely to receive adequate prenatal care and may even face criticism and judgment from those who disapprove of their pregnancy. Women with disabilities are constantly denied health care. Everyone should be alarmed and concerned when reading these statistics. But why are these problems prevalent in the first place? It is no longer acceptable to not have women at the table. It is no longer acceptable to not have people of color at the table. But no one thinks to see if the table is accessible. Just a little story time. I was just a personal story from a couple of months ago. I was out in the city with my husband and we went to a restaurant, went for dinner. And the place we went to eat had a step to get in. I use a manual wheelchair, so popping up of one step is doable for me, but not for a lot of people with disabilities. So as an advocate at heart, I went up and spoke to management and suggested that a small change like adding a ramp would welcome so many more people into their business. And what he told me was that it never occurred to him to build a ramp because disabled people don't frequent his business. Yeah, so it never occurred to him that the reason that he doesn't see disabled people there is because the place is inaccessible to begin with. This is something that is something common that people with disabilities face every day. Disability is a constant afterthought, even though 26% of Americans have a disability. We are the biggest minority in this country. If we go back to the next slide, to the slide. I always think of this Judy Heumann quote when describing the root cause of this systemic problem, and that is ableism. So what is it? What is ableism? Ableism is a set of beliefs and practices that devalue and discriminate against people with physical, intellectual, or psychiatric disabilities. It often relies on the assumption that people with disabilities need to be fixed. Systemic ableism is a system of institutions, policies, and societal values that disadvantage people based on one's intelligence, physical ability, and mental abilities. Ableism fosters misconceptions, stereotypes, stigmatization, and false beliefs. It devalues and characterizes groups of people as less than, very similar to racism and sexism. Just like racism and sexism, ableism is what's holding people with disabilities back. Disability isn't a tragedy. It's a neutral term, but unfortunately, the medical system never views it that way. And in a system designed to fix the broken, people with disabilities are viewed in negative perceptions. These views impact the quality of care that we receive and leads to health disparities. I truly believe that society needs to understand that disability rights are human rights. It is our right to have equal access to healthcare. So what are the reasons? What are the problems? Women with disabilities often face barriers that stop them from receiving equal and appropriate healthcare. They include physical barriers, attitudinal barriers, limited medical training and guidelines. Let's start with physical barriers. They consist of lack of adaptive examination tables and scales, inaccessible testing rooms, inaccessible diagnostic equipment. Over 90% of physicians' offices do not have wheelchair accessible scales, for example. Yet weight tracking is crucial for many reasons, including pregnancy, medication dosages that are based on weight, and also weight changes that can indicate underlying health issues. So, true story. The last time that I was weighed at my primary care physician's office was 18 years ago. That was before my injury. Doctors, yes, even my primary care, just ask if I recall when was the last time that I was weighed. Or worse, they just ask me to guess what my weight is. This is one of the many examples of a routine exam that you may receive in your primary care that you might perhaps take for granted. I, on the other hand, have zero access to when I go to my doctors. I luckily happen to work at the rehab department. So I'm one of the few lucky ones who has access to an adaptive scale for wheelchairs. This is not the case for most women with disabilities. Here are some examples of women with disabilities healthcare experiences. These were shared from the Raw Beauty Health Project. They're a nonprofit for women with disabilities dedicated to empower, educate, and inspire change. Most of the images that I used on this presentation are from them. And they do a brilliant job at telling these amazing women's stories and in raising awareness to these systemic barriers. You can learn more about their great work at www.rawbeautyprojecthealth.com, and it's included at the reference portions at the ends of the slides. You can also follow them on IG at Raw Beauty Project and see all the great work and advocacy that they're doing about this. Attitudinal barriers. Attitudinal barriers are behaviors, perceptions, and assumptions that discriminate against persons with disabilities. These barriers often emerge from a lack of understanding, which can lead people to ignore, judge, or have misconceptions about a person with disability. Some of these examples of attitudinal barriers are stereotypes, such as like positive or negative generalizations that people have about people with disabilities. The spread effect, which is the belief that a person's disability negatively affects other senses or abilities, personality traits, or the total person is impaired. Invisible, the attitude that you can talk over or ignore the person with a disability. Eternal children, the belief that someone with a disability will never be able to grow or to develop an adult, both mentally and or physically. Inferiority, the belief that individuals with disabilities are second-class citizens just because of their disabilities. And I would like to point out that most of these attitudinal barriers are unconscious biases and perceptions that people have. Many women with disabilities find the attitudes of healthcare providers a barrier to healthcare. They report erroneous assumptions, negative attitudes, felt being ignored, judged, insulted. Study shows that many physicians, for example, assume that patients with disabilities are not sexually active and therefore do not provide them with information about contraception, sexually transmitted diseases, or testing or cancers associated with sexual activity. Many surgeons also presume women with disabilities who are diagnosed with breast cancer prefer mastectomies to breast conserving surgery, under the false assumption that these patients don't care about their physical appearance. Due to my experience, for example, throughout the years, I can't help to think that due to my disability, physicians unconsciously assume that my quality of life is low. For example, I have lost count of the number of times where I can bring up a specific physical issue up to my doctors throughout the years. And their first question is always, how depressed am I? Attitudinal barriers from medical professionals towards women with disabilities are not just offensive, but can affect their medical care and outcomes. In order to receive equal health care, it's imperative to be seen as sexual beings and active participants in society. Due to attitudinal barriers, studies show that healthcare providers gather more information on pain, depression, stress from patients with disabilities and collect less information about smoking, sexual activity, blood pressure, cholesterol, mammograms, and cholesterol exams. Limited medical training and guidelines. The absence of professional training on disability competency issues for healthcare practitioners is one of the most significant barriers that prevent people with disabilities from receiving appropriate and effective healthcare. Studies constantly show that healthcare providers continue to lack awareness about steps that are required to take to ensure that patients with disabilities have access to appropriate culturally competent care. And in general, doctors are reported to lack sensitivity and understanding of disability and make erroneous assumptions based on disability. Believe it or not, they do not teach about disability in medical school. Disability competency is not a core curriculum requirement for accreditation, federal funding for most medical and dental schools and other professional healthcare training institutions. It's not a requirement for hospitals to participate in federally funded medical student internships or residency programs. And it's not a requirement to applicants who seek either medical or other professional healthcare licenses. What good is the ADA law, if it's never enforced? Federal agencies do not require that procedures be established to collect information that will reveal the extent of compliance with the ADA. In the absence of such requirements, no one is held responsible for physical and pragmatic accessibility in the healthcare facilities and programs. Without robust ADA enforcement, the disability rights laws are ineffective tools for challenging discriminatory conduct or care that people with disabilities often report experiencing. So, what are some solutions? Professional education, training, and technical assistance. Information related to disability cultural competency is lacking in most professional medical education programs, and only limited information is available for healthcare institutions and providers about methods to ensure physical and pragmatic access for people with disabilities. I can't stress this enough. We must include disability cultural competency curriculum in all medical, dental, and allied healthcare professional schools. Currently, very few medical schools require sufficient disability competency training for students. The next solution would be monitoring, oversight, and accountability. Implementation of key disability rights laws by healthcare systems, managed care organization, and healthcare providers directly affects the quality of care available to people with disabilities. What good is the law if it's not obeyed? Healthcare systems must follow the ADA. Accreditation. Accreditation organizations must access facilities for basic compliance with ADA's accessibility guidelines. Again, the government, what good is the law if it won't be implemented? Why don't my rights as a person with a disability matter? And the last solution that I propose would be universal design. Universal design must be applied in all aspects and venues of healthcare, ranging from facility designs and constructions to the development of quality measures, research design, and delivery of care that embrace everyone, including people with disabilities. We must design with accessibility and future in mind. And I can talk all day about guidelines and regulations that would help. But at the end of the day, until ableism becomes a conscious thought in non-disabled people's minds, only then will true equality be achieved. The real change will only happen when disabled people are heard and put at the center of conversations. Look around your spaces. See how accessible and welcoming they are for people with disabilities. And think of ways to advocate for these changes in your networks. Talk to people with disabilities, get to know us, follow disability activists on social media. Ask how you can be an ally for disability rights. Now for some good news, I would like to discuss some of the research projects that the Spinal Cord Injury Research Program is currently working on to improve health outcomes for women with spinal cord injuries. So one of them is the improving healthcare access for women with spinal cord injury. Our goal was created focus groups, which included women with spinal cord injuries and family and professional caregivers that work with spinal cord injuries population, to identify the 3 most important factors women with spinal cord injuries who live in New York City consider deficient when working with different healthcare professionals. And our goal was to develop a training module on PEAK to facilitate sensitivity and equality improvement training for physicians who specialize in OBGYN, urology, and ER medicine. We are currently working on the Sinai's interning PEAK training. So this is how the PEAK training will look like. We are focused on 4 modules, which would include medical issues and clinical competency for providers, communication and interaction, myths and misconceptions, and equipment accessibility and transfers. We're hoping to have the PEAK training completed by the end of this month. So please be in the lookout for the training and please share the word with your colleagues as well. Our next slide, we can share what our other study is. And this is enhancing healthcare for women with spinal cord injury through a web-based information resource. So we created focus groups with women with spinal cord injuries and identified the 5 most important factors that women with spinal cord injuries consider when selecting healthcare professionals. And we pretty much created a web-based national resource website that can serve as a comprehensive directory for the most important healthcare factors to all stakeholders. Overall, we found that the 5 most important areas that women with spinal cord injuries find important are access, advocacy, bowel and bladder care, gynecological care, and mental health. So we are presently working on the website. Unfortunately, I cannot share that link with you all. But when completed, our goal is that we would create a directory for women with spinal cord injury to find accessible health services that they need. And so for more information on both of these research and our other research projects, you can visit mountsinai.sci.org. Or you can also follow our program on Instagram, Mount Sinai SCI. And so before I end, I would like to go back to just to my original quote, which I think was slide number 3. So I hope that my presentation sheds some light on the numerous barriers women with disability face in healthcare, and it plants a seed in you to recognize your own assumptions and biases that you may have about women with disabilities or people with disabilities in general. We all have them. And to just be more mindful and to advocate for changes to improve these outcomes. Women with disabilities are powerful and resilient. We overcome many challenges on a daily basis. Accessing equal health care should not be one of them. All right, and thank you.
Thank you so much, Ariane. Wow, this is a lot of good information, and thank you so much for sharing your experience with us. I want to invite the participants to enter any questions or comments you may have in the Q&A. Ariane is going to stick around to answer any of our questions. I do have a couple questions for you, Ariane, while the audience thinks about what they might want to inquire of you. For you personally, what do what is the most of the barriers that you talked about? Which is the most difficult, do you think, is most difficult to change or to move the needle on?
Wow. Well, out of the 3 that I really spoke about, I think the hardest one would be the attitudinal barriers, because that is more than systemic. Like it has to be we have to have training from the beginning in med school about just disabilities in general. Like, disability is not an overall tragedy or overall negative. And like, these views about people with disabilities do affect the way that like physicians care for us. So I feel like that, like starting there, like has to be the biggest, I think that's the biggest barrier, because it has to be like from scratch, you know, from
Mhm.
med school.
Yeah, thank you for that. You know, there's a lot of disparities that you had shared about access to screenings and different tests. Um, I was wondering, you know, has your department done any studies on outcomes related to some of the attitudinal barriers that patients face?
Yes, so some of like the focus groups for the two studies that we're currently working on, those were the issues that arise, right? So we would ask what to tell us their experiences on these focus groups, and a lot of women a lot of their experiences were similar. They felt that doctors just assumed, made just ever assumptions about their lives due to their disabilities, or there's just no access to begin with, especially for women with spinal cord injuries. A lot of our injuries are very physical, so just transferring to get a proper physical exam. Women with disabilities are not getting those proper exams. Doctors are telling them, if if you need to bring someone with you to transfer you, because we can't do that. We can't help you, which is against the ADA, right? So these are the things that they're constantly facing. That are barriers to getting the services that they need and want.
Mhm. Could you talk a little bit more about the spread effect? Because I think that's a very interesting concept that I think is worth discussing a little bit further in detail.
Right. I would say like a very common one would be for people to, when people speak very loud to a blind person, for example. That would be like a very obvious one, where you see a disability and then you just assume that something else must be this, there must be some other type of disability that that person has as well, just because they're disabled. So yeah, just people assume that you, just because you cannot walk, you're in a wheelchair, that you might have an intellectual disability. Just those type of assumptions.
Mhm. So is your department doing any education or training right now for the students or the trainees around disabilities?
So where we're doing is the PEAK program right now, which we hope that, we can, once it's up and running, everyone from the healthcare from Mount Sinai have access to it, so they can go in there and do the training. And it is pretty much just like information about women with disabilities, because spinal cord injuries, they're just like the information that doctors that know it's very, very small out there. So we're hoping that that people just do the training and become a little bit more familiar about the issues that this population are having when they go for services.
Mhm. I also, thank you so much, Ariani. I also want to invite the audience to please share any questions you may have for Ariani. I'll just pause for a few seconds to see if anybody has anything else they want to offer. Ariani, so what typically happens when you are in a medical office and they don't have the appropriate equipment, or they can't provide a medical service for you, or even the patients in your focus groups? Like, what's the alternative? Do they just don't get the care?
Yeah, that's pretty much it. Unfortunately, a lot of women are just turned away from certain centers or clinics that we just can't help you. It's just not accessible here. Go somewhere else. But that's most places, right? So it's a problem that we are constantly facing.
Mhm. And so are they any movement to train, students and trainees and the other allied professionals in the disability community?
Well, we're hopeful that this peak training that we're doing, at least for the spinal cord injury program, can be taken nationwide. Like our goal is to try to get a grant and make this like nationwide in all peak programs, all networks that provide it, and hopefully to spread the word on that. So our goal hopefully is to do that. Yeah.
Mhm. Great. And I know your focus is spinal cord injury, but
Yeah.
has there been any discussion about looking at other types of disabilities and creating trainings or modules for other types, like neurological or, different types?
I'm not really sure what the department like in overall is working on. If they have anything like that, I'm just not really sure.
Mhm.
But that's what like we're working on specifically with our population. But I mean, I hope that's something that everyone should be thinking about. As you had mentioned before, where we've spoken of just having a trainings in medical schools to begin with, and not waiting for this, for the specialty to already, for the trainings once they're already in their specialty.
Mhm. Thank you. I do see a question. One is, do you think the larger problem is the need for healthcare as a whole to cater to the majority only when those with disabilities are a minority? Or is it an individual level issue with physicians not taking the time to be properly aware of how to treat those with disabilities? And Ariane, before you jump into that question, I do want to say, according to the CDC, I think 1 in 4 Americans have disability. And
Right.
2% of our patient population, and that number is just going to get larger as the population ages. And keep in mind, a disability can happen at any point in a person's life, and it could be temporary or it could be lifelong. You could be in a motorcycle accident, what have you, or you could have it since birth. So Ariane, what are your thoughts about that? Is it that, the larger problem, the need for healthcare as a whole to cater to the majority only when the disability, is only a minority? And is it an individual issue of physicians not taking the time?
Right. So I as you had mentioned, disability it's not really a small population of Americans. 26% of Americans have some type of disability. That is millions of people. And I think that the problem is that they're just not trained. There's no training. There's no even a concept of disability in the medical school. So that's the problem to begin with. There's just no proper training of how to deal with people with disabilities.
Yeah, so it sounds like a systemic issue.
Yes.
Another question is, would you agree that New York City is one of the least friendly cities to people with physical disabilities, subway, outdated elevators, etc.? How does that impact the community, their ability to get to and from work, receive medical care, etc.?
Yes, that's definitely an issue. I definitely was highlighting the healthcare issues, but there's systemic problems everywhere that affect healthcare as well. And one of them is transportation for people with disabilities. It does affect disability affects all aspects of our lives, but again, it's the same reason. It's ableism, right? Because it's access. If everything was accessible, the trains were accessible, if their elevators were working, we wouldn't have an issue to getting around. It wouldn't be a problem, right?
Yeah, thank you for that, Ariane. Yeah, when you think about ableism, right, and about systemic issues, like our environment is constructed from an able-bodied perspective, right? Our buildings are constructed from an able-bodied perspective, with stairs, right, or narrow hallways or bathrooms. And so, you know, I invite all of you during this month, you know, with disability awareness, you know, thank you for taking the time for joining us today, but also thinking of just looking around your environment, you know, whether it's in the office, you know, the structure that you live in or you work in, or your, you know, or your commute, you know, think about from, you know, from an able-bodied perspective versus, okay, well, what if I did have a disability? What if I did have knee surgery and I couldn't, you know, there wasn't a lip in the sidewalk that I couldn't get over or something, right? So really take this time this month to really think about your environment and how accessible it is, and what we can do as a community to improve that, for, you know, our coworkers, our patients, you know, as we move forward. Ariane, any last words before we sign off? Any key takeaways?
Well, that was a very good closing. But yes, I would just like to add to just be more mindful of like the experiences that other people might be having. And also to be aware that disability is not something like it's so foreign to people, but it can happen to anyone, right? Like you can become disabled at any point in your life. This is not something that that you should just worry about because of other people. Also, because you never know, you might be part of this community in the future as well. So just think about those things, and be mindful of those things in your surroundings.
Yeah, and also I just wanted to invite you all. We have a employee resource group called ADAPT, all differing abilities partnering together. So if you know, are interested in advocating and being an active ally in this area, please reach out to us here in ODI and we'll get you on the email list. So if there's no other questions, Ariane, thank you so much for taking the time for presenting this great information to us today. And thank you. Thank you.
Thank you. Thank you all for having me, and thank you all for joining us.
Yes, and look out for the peak training too, right, Ariane?
Yes, so be in the lookout for when that's available.
Any time frame on that?
In the next couple of weeks, like early November, hopefully.
Okay, great. All right. Thank you, everybody.
All right.
Bye-bye.
Bye.